My name is Dr. Victoria Wamuhoma. I'm a consultant psychiatrist here in Mathari National Teaching and Referral. We have been a psychiatrist for the past decade, and I have some special interest in child psychiatry. Today, I'll be talking about Autistic Spectrum Disorder.
So, Doc,
Yes.
What is autism?
So autism is a neurodevelopmental disorder. So it falls in a category of several other disorders. It's not the only one there. We also have attention deficit hyperactivity among others. But what I would want to say about autism, just to differentiate it from the other neurodevelopmental disorders, is that it presents with deficits or deficiencies in three main domains. So the first domain is in the social domain. The second domain is in language and communication. And the third one is abnormal behaviors, which are usually classified as stereotypic or repetitive behaviors. This disorder, because it's a neurodevelopmental disorder, it is diagnosed in children in very, very ideal situations like world-class hospitals. It can be diagnosed even before 1 year, even within 6 months of birth. But in Africa here or in our settings, most of the time we diagnose it by the age of 3.
And just a while ago, you were telling me about the three major areas.
Mm-hmm.
Maybe you can expand on that and how they present themselves.
Okay. So the three major areas are the language areas. And I think I would want to talk about how a parent who has a child with autism will notice that their child has autism, or how parents who've had some comments on somebody maybe making a comment that have your child checked for autism, how the child would actually be presenting. So I talked about the social domain. So the number one characteristic feature in that domain is that the child does not have eye contact. So you have a child who doesn't look at you, or a child who is not responsive when somebody is talking to them. So the child seems to be looking elsewhere, or the child sometimes seems to be daydreaming rather than paying attention to them when attention is called towards them. Or there are parents who may complain, mtoto wangu hasikii. But again, the parent is surprised because there are times when they call the attention of the child, mtoto anasikia. So you'll find that this type of parents have also done what is known as audiology tests. So wanapeleka mtoto hospitali kuangaliwa kama anasikia. And that's very common in children who have autism. So that is in the social area. The other thing about them that is very characteristic, remember we said that they have deficits in socialization. They don't play with other children. So most of the time they'll be playing alone. Or the other very characteristic thing is that we know very well when your parents have not been at home, most children will run and rush and hug their parents. So a child with autism, most of the things that the parents may notice is that hata mama akirudi nyumbani, kama mtoto alikuwa anacheza kwa kona yake fulani, ataendelea tu kucheza. Yani ni kama hapay attention, ama hanotice ya kwamba mama amekuja ama baba amekuja. So that is also another thing. And as they grow older, the parents notice that they don't maintain friendships, or they don't initiate friendships, or they don't stay within friendships. They are usually loners. The other thing is also noticed in how they play. So we said they play alone, but even how they play with their toys when they are younger is very different. So a child may like toys of a certain color, or if the child is playing with cars, instead of riding their cars on a surface, they may pick only one particular area of that toy, like if it is the wheel of a car, and they'll be spinning it for hours. So that's one way, but that's in the social domain. So let's move to the language domain. So the language domain is very interesting. There are children who may develop language, and then there are children who will not develop. There are children who will develop language, and we'll talk about that. Then there are children who may not develop language at all. Then there are children who develop language up to the age of 3 years, and then they lose it. So their parents will say mtoto wangu alikuwa anaongea vizuri sana mpaka wakati alifika 3 years. Then sielewi, akaanza kulose vocabulary, na mwishowe akalose everything. Or it might be a parent who may say, I expected my child to have stayed babbling by age 1.5 years and then develop speech, but then the child actually did not develop any speech at all. So we have this type of kids who also don't speak at all, but they are not deaf or dumb. Then there are children who develop very good vocabulary, but unfortunately, if you look at how they speak, they have very ordered or very formal types of communication. So they don't understand what is known as normal social nuances. They can't gossip, they can't involve themselves in chit-chatting and all that. They don't understand that kind of language. They understand very, very formal language. Then for those children who will not have developed any language at all, they may also develop what is known as non-verbal communication. So we have children in the clinic who the mothers, so when we ask them, unajuaje mtoto wako ako na njaa? Mama anaweza sema, mtoto huwa anaenda anachukua sahani ananiletea, na akifanya hivyo najua ako na njaa, ama anashika tumbo kuonyeshana ya kwamba ako na njaa. Or the other thing is that, na unajuaje mtoto anataka kwenda choo? So maybe mtoto atatag ama mtoto atapoint. So the reason why this disorder is called a spectrum is because not one child will be like another one. They are very different in how they present, and it is almost like on a spectrum. And let me not forget the last one, which is the repetitive behaviors or the stereotyped behaviors. Hawa watoto wanakuwa na tabia za kurudia kitu. So a child may like something so much, and they have some characteristic behaviors around some things. A child may like spinning. A child may like flapping their hands or clapping or playing with water. That is also very common. It is something that I've seen in the clinic. And they can do this for hours. And the reason they do this is because it is also a self-soothing behavior.
So for a parent or someone who has commented about autism, what would they be looking for?
So they will look for the symptoms in the 3 areas that I've told you about: the language, social, and the stereotyped behaviors. But other things that can also be seen is that sometimes these children also have delayed milestones, what we call delayed milestones, some of them. So mtoto anaweza kuwa alitambaa late, ama alitembea late, ama vitu zingine pia zili develop late. The other things that are characteristic about these children is that they love routine and order. So in the house, the parent may notice that they like a certain routine, and when that routine is tampered with, the child is not happy or they become very irritable. Parents may also notice that when you take this child out of their home environment to a new environment, the child also becomes very irritable and they don't like it. Some of the children also may have what we call self-harming behavior. So they could either scratch their skins, or they could bite their skin, especially here or on the knuckles, or they could also bang their heads on walls when they are agitated. But the 3 main areas to look for is the social, especially eye contact when a baby is very young. Even a breastfeeding mother can start seeing signs, and that's why in world-class environments, even a child who is less than 6 months can be noticed, because we always expect that a breastfeeding baby is looking direct in the mother's eyes. So you'll find that these children don't really look at their mothers directly in their eyes. But basically the 3 areas I've talked about are the areas that parents may want to be looking at.
Okay, there's a notion that autistic children are very smart.
Mm-hmm.
How is their performance in school?
Yeah, thank you very much for that question. So what the very small percentage of children who are very smart, and it's a very small percentage. Unfortunately, it's actually less than 1%. But it is because they are so smart in that one area. That's why it is usually very pronounced, and that area is usually projected a lot in movies. So you may find a child who is extremely good in music, or extremely good in history, or extremely good in mathematics, and they can do the maths all the way to professorship. But if you look at all the other domains of education, they're actually not very good. So they just pick one area. And but most children who have autism, actually, they don't do well in school. And it can again have a range whereby you can have a child who cannot write, cannot read, ranging all the way to, again, that special category, who are very smart, but in one area, not in all areas. It's very difficult.
Okay. And what are the comorbidities of autism?
So we said autism is a neurodevelopmental disorder, and it is usually associated with sometimes with others. Sometimes it can come alone. Sometimes it comes with other disorders like attention deficit hyperactivity disorder, or even seizures, and then of course intellectual disability. Hiyo yenye nimesema ya kwamba milestones zinakuwa very slowed in the child. So again, the parents have to, things become very complicated when there are comorbidities, again, because those other disorders also really affect children in those three domains.
Okay, and where can they get help?
So parents who have these kids, they can get help in schools, but they can also get help in hospitals. So a psychiatrist or a child psychiatrist will be the first contact. So a child psychiatrist would want to evaluate this child, confirm that it is autism, confirm their capacity, and then rule out other comorbidities. So a psychiatrist would want, once they rule out the comorbidities, or they check out the comorbidities, then we can know how to manage. Especially if it is seizures, then we want to treat the epilepsy, ama kifafa. If it is attention deficit hyperactivity disorder that is comorbid with it, then the parent may want the doctors and together with the parent, because how to help these children is usually actually a collaborative effort. It is not a one-person show. Then they may want to adjust some things or even give drugs for the attention deficit hyperactivity disorder if it is very severe. If it is pure autism and probably the child has aggression or the self-injurious behaviors, then the doctor may want to manage that aggression, or they want to manage that self-injurious behavior, either using psychological interventions or using medication. Sometimes we have to give medications for those. Now, what are the other available helps or available things that are available for these parents? Number one, we want to empower the parents. The parent is actually the link. The parent is the focal person, because the parent is the one who spends most of the time with this child. So we empower and teach parents how to do schedules and how to manage time for these children. We encourage these parents to really socialize with these children, but also to take them for speech therapy where affordable and accessible speech therapy. Otherwise, we teach parents how to really engage with these children to try and improve on their communication skills. In schools, in schools, the child can be enrolled in a special school or in a school specifically for autistic children, but those are really expensive and those are for parents who can afford. The other things we encourage parents to do is to engage these children in helping out in the house, doing chores, washing dishes. That is just specifically to help the child develop what is known as adaptive skills.
What is your parting shot in autism?
Yeah, my parting shot would be to encourage parents who suspect their children to have autistic spectrum disorder. They can bring them to Mathari Hospital. Every Wednesday we have a child psychiatric clinic where with very qualified psychiatrists who are able to assess your child and actually confirm a diagnosis if it is there. If not confirmed, then rule out other comorbidities. But we also have other supportive structures like the psychologists and the occupational therapists who also help in taking care of these children. So I just want to encourage people not to be afraid, but to come. We see their children every Wednesday. The clinic is open and very affordable.